Swayam Prabha. Digital India. Educated India.
Welcome friends and scholars. It's indeed our pleasure to give you the content on health economics as part of the NPTEL MOOC module. In this last week, we are targeting to do a content on Indian health system and their challenges. As we know that the Indian population have indeed faced a greater challenge, especially at the time of COVID. Number of issues were unearthed, number of problems were in fact highlighted. Hence, after discussing over last 11th week, and even this week we discussed couple of lectures, we thought it's also good to conclude with some clarification on Indian health challenges. Hence, the lecture is targeted accordingly. We are focusing on health status, what is exactly with us, and its governance patterns and future challenges. These are in fact our targeted this lecture. Coming to understand the Indian health system, since India has a federal structure of governance of healthcare, we have purely two tier, though another extension is still three tier system as per the governance is concerned, political approaches are concerned, but health wise it is of two fold. One is center and state, central subject and state subject. Coming to the understanding of public health, sanitation, hospitals and discrepancies, it is purely part of a state subject, where it is indeed the responsibility of the individual state to manage the public health. Whereas the population control, family planning, adulteration of foodstuff, control of infection or infectious and contagious diseases across the state boundaries, and issues governing the medical profession etc. are part of the concurrent list, where both center and central government and the state government act together. Similarly, legislation, vision, financing and delivery of healthcare services are part of the state government. Funding from the from state government are of how fundings are there. 2/3 of the public health expenditure in India is from the state government, and the rest consisting of that is 1/3 is from the central government contribution as per the public health delivery is concerned. So, 2/3 plus 1/3 is the ratio where the public health approaches are made. So, as I said, this is state government bears, this is central government. Okay. So, you can understand this way. Now, policy formulation, regulation on health insurance are largely under the jurisdiction of the central government. Another aspect which is highly discussed in the present days is called social health insurance, and this is part of the concurrent list. Both the state government and central government deal with it. The central government framed and produced vision and strategy documents time to time, that is NHP, the National Health Policy of there are different central government policies and documents. Some of them we are just mentioning, which are very important, which are framed over time. One is the National Health Policy of 1983, then 2002, then 2018. And guidelines concerning Indian health, public health standards are also discussed. So, the latest in fact is actually emphasized on this 2018. Health services in India delivered by public for profit motive and also for not for profit private providers as well. There are in fact so far we discuss about the health system largely governed by the biomedicines, okay, but still in India in practice there are alternative medicines as well, alternative system of medicine or the indigenous medicine. It is also called Indian System of Medicine, ISM. Okay, so though as a comparison with other countries, these are also part of the definition of traditional medicine. It includes the famously called Ayush, and the acronym of it, Ayurveda, Yoga, Naturopathy, Unani, Siddha and Homeopathy. So, even there have been also some revision as well, you can also include. Soya Rigpa is another part of the new definition. Okay, so, as part of the definition of Ayush. Coming to the understanding of Indian health system and its structure, it has 3 levels: primary at the primary level, secondary and tertiary. Primary includes your primary health center, that is PHC, and also the sub centers like if you are pursuing your degree from any universities, they might have some health unit. Usually they are considered to be the PHC or even at the below level called sub centers. Okay. So, whereas it you might be surprising to know why this is actually located even if the population is very low. Yes, it has to be the standard definition of this distribution is through population only, largely through population. We will also discuss that. Hence, if your university is inhabited by less people, then obviously there will be a possibility of sub center. Then at the secondary level, usually the surgical components are included, such as community health center. Some that these unit deal with inpatient delivery as well, or inpatient treatment as well. Hence, these are at the community level, hence that is those are called community health center, CHC. There are super specialized hospitals, such as in short they are called tertiary level hospitals. This includes hospitals and medical colleges. Okay, so we will discuss these things in detail. As per the guidelines, population really matters to distribute these units. Indian government also followed this. Coming to the definition of sub centers, the coverage of population should be 3000, including hilly and tribal backward areas. Okay, so 3000 for if it is hilly and where the population density is very low, so hence it is 3000. Whereas in general in the plain area it is of 5000 to have a sub center. Coming to PHC, it is the range of 20,000 to 30,000, and CHC it is 80,000 to 120,000. Once again, understanding sub centers, we just say the range is from 3,000 till 5,000. Most peripheral, and this is first contact point of the population, close to the neighborhood. Like you might have heard in Delhi model called Mohalla clinic. They usually considered to be at the sub center level. That is catering to the direct need of the population. Even the Mohalla clinic model as mentioned in the in the documents or even the news channels, that it also includes so many facilities, okay, which is at a very minimal effort and even cost. Cost is almost free. Okay. So, the total number as per the latest rural health survey 2021-22 report, that is considered to be the latest at this moment. So, total number of sub-centers are 1,61,829, rural are of 1,57,935 and urban is of 3,894. Whereas, coming to the PHC, that is at the primary health centers, and the population as we mentioned is actually of 20,000 to 30,000. I think we have already discussed this here. Okay, so sometimes you might confuse at the tertiary level called district hospitals as well. All right, so that's here. So the definition for it is, for the PHC is of 20,000 to 30,000 population. The total number as per the latest record, latest survey, it is 31,053 in total, including rural and urban areas. Now you can see the rural coverage is relatively lesser as compared to the sub-center level, whereas in the CHC community health center level, where treatments are made inpatient treatments are also dealt. You can see the rural is of 5,480 and urban is of 584. This is covering a population of 80,000 to 1,20,000. There is district hospitals, as I already mentioned, and you can also read as the sub-divisional hospitals. Then specifically their number is 1,275, both rural and urban. In particular to the district hospitals, the total number is 767, both including rural and urban areas. Indian rural health system, as I already said, sub-center, PHC and composed of these three, sub-center, PHC and CHC largely, and we already said that they are the most peripheral one and catering to the community largely. And as per the sub-center, one health worker, it's including ANM and then even one health worker, female and male. Okay. So, ANM stands for auxiliary nurse midwife, and this is as per the Indian public health standard, and total staff is considered to be 3 as the minimum one. So, this is the IPHS norm, whereas in case of PHC, the it's a referral unit for 6 sub-centers. That means sub-centers are part of the PHCs. So, one PHC is holding or regulating or observing or managing 6 sub-centers. So, it is considered to be having 4 to 6 bedded hospital. A medical officer is in charge, whereas in case of sub-center, it is the ANM is more important, and beds provision are not there. The subordinate paramedical staffs are recruited, okay, and total staff is expected to be 15 minimum as per the norm. Where in case of CHC, you can see it is holding at least 30 bedded hospitals. The hospital is holding 30 beds, and it has a referral unit for 4 PHC. Okay. So, 4 PHC are under this one CHC, and those PHC are supposed to refer to this CHC for further consultation. As I already said, this includes inpatient treatment, hence these CHC include specialized services as well. Total staff is expected to be 25 minimum as per the IPHS norm. All right. So, you might have understood the hierarchy of the hospital or the healthcare system in India. Once again, understanding the sub-center and their assigned task, they relate to interpersonal communication to bring about behavioral change. The public services in different programs, the sub-center includes like maternal and child health, family welfare, nutrition, immunization, diarrhea control, communicable diseases and non-communicable diseases. You must have seen the work of the ANM in your area, in your village or your locality, and this is are largely the provision attached to those ANMs or in the sub-centers. As per the PHCs, primary health centers, This is established and maintained by the state governments under the minimum needs program MNP and the basic minimum services, that is also called BMS programs. The first point of contact or the contact point between the village community and the medical officer. As I already said in the previous case, sub center hardly you have a medical officer, but some trained DIs or the ANM staffs are there. Hence, any better needs are required, they refer to a medical officer. Here a medical officer is recruited. So, the assigned task for them is to have a curative and preventive healthcare, then promotive and family welfare services. They emphasize on preventive and promotive aspects of healthcare, as I already said. Coming to the CHC, these are established and maintained by state government under the minimum minimum needs programs, MNP and minimum basic minimum services, BMS. So, they require to have 4 medical specialists, including surgeon, physical obstetrician and gynecologist and paramedical or pediatrician. Most importantly, there must be one obstetrician or gynecologist and physicians. So, we discuss about the requirement of these 4, that is surgeon, physician, either obstetrician or the gynecologist and pediatrician. So, these 4 includes also paramedical and other staffs. The task for them is curative and preventive healthcare, promotive and family welfare services. They also emphasize on preventive and promotive aspects of healthcare. Now, we are discussing, after understanding the structure of our Indian health system, we are discussing the challenges, especially which are identified through the shortfalls. According to this RHS 2021-22, as of 31st March 2022, the overall shortfall in the post of health workers, maybe female or ANM, that is of 3.5% of the total requirement. So, 3.5% as per the norm of this requirement for the sub center and PHC, excluding the surplus in some of the states. So, I mean excluding the surplus in some of the states, the shortage is of 3.5%, and this is the standard of IPHS. Then the health workers male wise, the shortfall is of 66.6% of the requirement. So, the requirement wise we have a 2/3 shortage. At the PHC level, it is of 37% of the sanction post of health assistants for male and female, whereas 23.8% of the sanction post of the doctors are also vacant. That is why it is largely debated and questioned to the government about the shortfall. Even the post-COVID has witnessed the problem of dealing with the issues at the ground level. At the CHC, out of the sanction post, 71.9% of surgeons, even these are all as per the requirement. 71.9% of surgeons, 63% of obstetricians and gynecologists, 67.5% of physicians and 69.7% of the pediatricians are vacant. Okay, so, that is, you can just note at the CHC the situation is even worse. Okay. So, I mean largely 2/3% is actually vacant. Okay. So, more than 2/3, that is a serious aspect. So, a patient who is thinking of getting treated at the CHC level, especially in public health system, at a very tertiary level care. So, the treatment is considered to be with a probability of 1/3, less than 1/3. Hence, the patients are actually at the prey of higher cost, and hence the out of pocket expenditure is very high in India as compared to even the underdeveloped and developing countries. Now, you can refer to our news editorials. We have written about this and highlighted how Indian patients are actually suffering from high burden of spending. The overall shortfall of 79.5% of specialists at the CHC as compared to the requirement for the existing CHC. Okay, so, now you can just see from the pyramid structure about the components of urban healthcare delivery model. So, Indian urban healthcare delivery model follows similarly to a pyramid structure as per the need, hence the community level requirement is more. Okay, so, and urban health centers are comparatively lesser, then the public or impaneled secondary or tertiary providers are actually quite less, few in number. So, National Rural Health Mission, National Urban Health Mission, NUHM, we are now referring to urban healthcare system. Coming to NUHM on 1st May 2013 as a sub mission under National Health Mission. Again under National Health Mission, two components usually discussed, one is for urban and is for rural. So, we are focusing on the urban side. So, hence a sub mission is targeted on 1st May 2013 for providing equitable and quality primary healthcare services to the urban population. Special focus was on managing or handling the dwellers in the slum area and the vulnerable sections of the society in urban areas. NUHM is designed to provide health services at the facility level and at community level. Now, this is what I was actually referring about Mohalla clinic. Okay, that is part of the urban urban health mission. Though yes, we will also mention it is the responsibility of who is the state government or the center. Actually, largely it is 2/3, as we already said, it is at the state government level. Coming to the community level, the outreach services by ANM and the medical officer, specialist, home visits by ASA and ANM are important. They deal with preventive, promotive, basic curative healthcare. So, the primary level healthcare facility includes, likewise we mentioned, but in the urban areas it is of 50,000 population. So, the coverage are preventive, promotive, curative, rehabilitative and palliative care. The services include OPD consultations, laboratory services, drugs, contraceptive dispensing, delivery of reproductive and child health services, multi-specialist services, population based screening, referral services and others. Okay, so, here it is about the urban community health centers, that is also called UCHC, not CHC. Okay, it is specifically for the urban. Yes, though. So, UPHC, SWC, that is health and wellness centers. This ensures delivery of comprehensive primary healthcare services existing for the UPHC would be converted to health and wellness centers. Okay. So, this is important so far as the urban health centers are concerned. This has referral facilities for every 4 to 5 at the PHC, urban PHC level. Likewise, in the CHC in the rural areas. Okay. But this has a coverage of 2.5 lakh populations to 5 lakh population. This includes metro cities, especially in the metro cities for every 5 lakh population with 100 beds are mandatory requirements. Inpatient services, medical care, surgical facilities and institutional deliveries facilities etc. are the part of the need as per the standard. Here is the work we are referring to Professor Selvaras et al. And their work of 2022. This is about organization of health, the relationship between the union and state and district levels. You can see at the union level, state level and the district level. So, starting with the union level, it is the umbrella under Ministry of Health and Family Welfare. So, within the Department of Health and Family Welfare is attached National Health Mission, then as per even partly addressed by Niti Aayog as well under National Health Authority, that is also called PMJY. Okay. So, again you can see at different level, at the state level, State Health Society, then hence you can see Director of Medical Education, Directorate of Health Services, Directorate of Planning, Directorate of Drugs Control, etc. Directly from the Niti Aayog and this connection with Minister of Health and Family Welfare, you could see health, state health agencies, then district implementation unit, then also specifically to the empaneled public and private hospitals where the PMJY is also implemented. Now, you can see wherever we have made a non-continuous or the sporadic dotted line, those have alternative funding channels, whereas the red one, the blue one, that is the red one is actually highlighting the newly established health and wellness centers. Okay, so whereas you can see that in the green lines, specifically emphasizing, we have also mentioned here in the states where Directorate of Medical Education and subsuming organizations are actually separated, that is why it is in the box. So, at the district level you could see the sub center, PHC, then CSC, sub district hospitals, then district health society, everything will actually are part of the district level hospitals. So, these are the design as presented, hence we are referring. Coming to the last couple of discussion here, we are just giving you a background of our health status. Life expectancy increase over the time from 1970 to 2020. You can see 47.7 years till now it is in 2020 69.6 years. And this is lower than Sri Lanka, Brazil, China, even Costa Rica as well. States with the highest gains in life expectancy over the period are Uttar Pradesh, Tamil Nadu, Odisha, Gujarat, Bihar, Himachal Pradesh, Andhra Pradesh. India is undergoing a significant epidemiological transition, that is growing burden of chronic non-communicable conditions are very important. We are just referring from the Indian Health System Review to 2022 data for further reference to have your starting point of research. You can work further. I am not explaining much here. Basically, we are giving the background information about our health status. This is indeed encouraging health professional participation in health education and health policy is needed, and public participation indeed is important channel out of it. Now, the future challenges are, which emerge from our analysis or our discussion are like technological challenges, demographic challenge. Okay. So, as we have seen that technological challenge has changes have actually posed with other directions of the management of healthcare in terms of cost minimization, as well as there are some discussion of improvement in healthcare. Old age is an issue. India is continuously or steadily becoming aging, hence higher need of health demand is required. So far as the technological changes are concerned, this has actually also helped us to improve the health status. Though technological changes they are to embedded here to manage health system to simplify it, but there is a coexistence of improvement in healthcare. Hence, the aging is expected to be higher, and more health demand is also expected. Hence, it is creating a threat or kind of a challenge further to manage more burden in healthcare. Hence, it is called Sisyphus syndrome. So, higher HC is also expected. Similarly, there are challenge of international competition. Sisyphus syndrome, as I already said, it is derived from the Greek mythology, whereas who was a Greek person who was condemned to roll a lump of rock of a mountain only to see it slip out of his grasp just before reaching the summit, or forcing him to start all over again. Likewise, as I just said, technological change is actually posing another threat. As again we are starting with or dealing with more issues, and that has led to the paradigm shift in the health structure. So, we need to go further. we are discussing the challenges. Those are actually poised to be in a different form. With the technological progress, it seems to be redressing the problem of healthcare. Yes, of course, it has improved. However, it has actually increased the other challenges, such as the healthcare needs have actually increased, and the life expectancy is also higher. So, in both directions, the population of the country is actually demanding more healthcare. This is actually the Sisyphus syndrome, which we have started discussing. It is connected to the Greek mythology, where a person who continuously trying to load or lump up the rock to the mountain, but the person slips further. So, every time with some tools or technique starting from the beginning, that means actually it seems as if that our efforts are becoming highly burdenful and repetitive. Okay. So, increasing or mounting the load on the public health systems. So, the technological challenge which we have started discussing, it has process innovation, product innovation and organizational innovation. So, in all those directions, of course, it has actually helped to lowering our cost, but simultaneously, as I already mentioned, you could see there are other issues. Like in the organizational innovation, the cost of producing a good or service can be lowered by reorganizing production processes and including the restructuring of the entire firm. Now, as I already emphasized that the demographic challenge is an issue. Once again, additional healthcare expenditure is indeed required, since that we are shifting with a demographic patterns. So, because of higher life expectancy, so the higher life expectancy can be claimed to bias spending in favor of healthcare expenditure. So, there are three hypotheses which are important to maintain the status at the level, that is called status quo hypothesis. Present age profiles can be extrapolated into the future. Then expansion of morbidity hypothesis that predicts increased survival of costly individuals that would have or they would have died. Then time to death hypothesis, the expensive years prior to death will simply be shifted to higher ages. Last but not the least, to discuss that there are direct international investment in hospitals as well. The challenge will consist in dropping the domestic purchasing clause in pertinent laws that has been prohibiting social health insurance from negotiating with the foreign healthcare providers, as mentioned in Juipel's work of 1999. The advantage of multinational for-profit enterprises in terms of efficiency will have weighed against the possible benefits of a professional ethic orientation. So, after all, by saying all those things, I need to just sum up that international organizations are important, but we need to be very cautious how far this is actually increasing efficiency, at the same time dealing with the professional ethics of the Indian population. Okay. Besides, our healthcare system still requires more engagement of health workers, so that loading as per the WHO standards should be maintained, okay, should be addressed correctly. So, these are the important readings for your work. I think that is all, and rest we will give you the possible assignment questions. I look forward to your participation. Thank you.